Today, we will explore what RheumaXP by Sergio Lopes Viana from Brasilia in Brazil has to offer. Hey, my name is Kai Hermann. I'm a radiologist from Berlin in Germany, and I'm collaborating closely with Sergio from Brazil. So he set up a quite unique training curriculum for the knowledge of imaging in rheumatic diseases in Portuguese, in his mother tongue. And he recorded 16 lectures about different topics like fundamentals of arthritis imaging, rheumatoid arthritis, psoriatic arthritis, spondyloarthritis, both the axial form and the peripheral form. He's also digging into crystal arthropathies, juvenile arthritis, and also is dealing with degenerative changes and changes at the spine. So it's a quite comprehensive teaching curriculum that he is offering. And there are also hands-on sessions with cases that he has provided from his personal archive, and more than 100 cases are now in the BerlinCaseViewer database and are available to the students of this course. And I will show you one of the cases today, so you can learn on what's it about imaging in rheumatology, but also on the cases by Sergio Lopes Viana. So here you see the overview. So currently we have a short introduction that I provided, and we have 3 hands-on sessions seen here, but in total there are 7 sessions that will be made available during the course. The course lasts several weeks, but the cases and the lectures can be viewed over a period of 1 year. Looking at the first block of images and going to the first case, we see that we are here dealing with a 30-year-old woman that is diagnosed with rheumatoid arthritis already since she was age of 25. So those of you who think I'm able to speak Portuguese, I'm not, but of course I was involved in translating the cases, so I have some idea on what's written here. So there was pain in the hand and the wrist, and she also has morning stiffness. And morning stiffness is an important sign in rheumatology. If morning stiffness is longer than 1 hour, that's usually a significant morning stiffness that gives the rheumatologist some sign of a severe form of arthritis. Also, she had difficulty using her hands in daily life, routine tasks like opening a door, holding a cup or things like that. And she's also very tired, and that is called fatigue. And fatigue is a sign of systemic inflammatory involvement in many diseases, but especially in rheumatic diseases. On clinical examination, there was of course swelling in the wrist, but also in the MCP joints, especially in the 2nd and 3rd ray. And there was also deviation in some of the joints, especially at the ulnar. So looking at the images, so this case is featuring an MRI scan that was done at the institution of Sergio, and you see there are unfortunately no X-rays available, but these MRI images, they are showing us quite an interesting pattern, and it's also an extensive MRI protocol, so you can learn a lot also about how to perform MRI of the finger joints and wrist in patients with suspected arthritis. So our first sequence you can see here. You see it's in coronal slice orientation, as are the other 2 sequences that are shown here. And the first thing that you need to check if what type of sequence you are dealing with. So we know in general we have T1 weighted sequences, we have T2 weighted sequences, we have some special sequences like fat saturated sequences, we have sequences with gadolinium injection that we can do with or without fat saturation. And therefore it's quite a challenge to get to the right sequence just by looking at the image. And this is even more complicated at the peripheral joints as compared to, let's say, the spine or sacral joint, because usually you need some fluid component in the image in order to find out if T1 or T2 is the correct sequence you're looking at. So looking here at this sequence, we see the fat has a bright signal. Also, the fat in the bone has a bright signal. Of course, we see some defects in the bones here, in the MCP, in the heads of the metacarpal bones. There's swelling of the joint capsule. We see also some defects in the radius and in some of the carpal bones. And the resulting lesion is of low signal intensity. So we can assume this is a T1 weighted scan because this would either be fluid or active inflammation like pannus, and this would show up bright if this would be a T2 weighted image. So this is a T1 weighted image, and we are comparing it with our next series, where we see now that we see fluid very brightly, and the fat is now dark. If you compare it with the T1, so you see the fat is bright here and it's dark here. So that is a fat-saturated T1 sequence. Usually we use a stir sequence in order to image the entire hand. So we know now that there is fluid in the joints, that we see destruction of the joints because we see also fluid inside the bones, and the destruction can also better be visualized here on these T1 weighted images. And also this is destruction, a large erosion over here. We are very fortunate also to have a T2 weighted sequence, not for diagnostic purposes, but for teaching purposes. This is very good that we now have this T2 weighted scan. You can see if we compare the T1 weighted scan with the T2 weighted scan, that it's very difficult to really distinguish it if you are just stepping into the field of arthritis imaging. Fat is bright in both of the sequences. That's true for the subcutaneous fat, but also for the bone marrow and our inflammatory lesions, like the large defect here in the radius, or the areas here in the metacarpal bones. They show up bright in T2 and dark on T1. I think that can be better appreciated if we enlarge both of these images a bit. You see this is dark here and it's bright here. So if you imagine that you would just be able to perform a T2 weighted scan, that would be very difficult to check if there's inflammation, if there's destruction. Of course, after some time you can distinguish it. It's not impossible because the fluid has a slightly different signal intensity compared to the fat, but it is not a nice image to look at. Okay, so what else do we have? We have a sagittal acquisition. That's not a reconstruction, that's a sagittal sequence acquisition, where we can see there's inflammation in the proximal interphalangeal joint. In this finger, we see a lot of inflammation in the wrist. We also see malalignment in the wrist. We can see that that's the radius. The radius is quite good in its axis compared to the carpal bones and the metacarpals, but the ulnar has an oblique orientation, so we need to assume some subluxations of the subluxation of the ulnar. And usually I don't perform this sagittal acquisition due to time constraints in our institution, but what I always do is the axial scanning, because the axial plane shows you really the most detail that you need in order to distinguish what's going on. You see the contours of the metacarpal heads. You see the large erosion that is due to the pannus. The pannus is here, the bright area. And you see also a little bit of different structure here. There is this intermediate weighted signal, or not as bright as here. So you know already there's some synovial proliferation that we call pannus, compared to maybe the other joint where it is like a clear fluid, and we would not know if that is a fusion or if this is a synovial proliferation. Also, the axial slices are very well suited to search for tenosynovitis. For instance, here you see the flexor tendons, and there's some slight signal increase surrounding the tendons, so we would assume some slight tenosynovitis. Also here we have close vicinity of the extensor tendons to the MCP joint. So of course we can assume some inflammation around these tendons. And if we go a little bit further, we check if there's isolated tenosynovitis, but that doesn't seem the case at the fingers. But we see tenosynovitis here at the palm of the wrist. Also, synovitis surrounding the wrist bones can be appreciated here and is very severe. In order to check if there's active inflammation, usually gadolinium injection is warranted. And I'm starting with the coronal slice orientation again. So here we see again all the joints that are inflamed show up. And if you compare it with the stir sequence, so that is the stir sequence, and comparing it to the coronal T1 after gadolinium injection, so if you compare that, you can see that the same joints are showing up here. However, this is gadolinium enhanced. That means here you can be sure that there is vascular, hypervascular tissue and not effusion. Here in these sequences, it's still doubtful if there's just joint effusion, which would be less, would be a weaker sign of inflammation. But after the gadolinium injection, you see clearly that this is active pannus tissue. So in this particular case, I think the diagnosis was already clear based on the unenhanced sequences, but usually protocols are requiring gadolinium injection. And also here we have the axial images that we can appreciate here, and you see that is pannus here that also goes into the bone. So we see a case of active rheumatoid arthritis with destruction, and we have erosion, we have pannus, we have a slight amount of tenosynovitis, especially at the wrist. Synovitis in many joints, so it's a polyarticular manifestation. We also have tenosynovitis here in the extensor carpi ulnaris tendon, and also a little bit of bone marrow edema was visible. That's not the most prominent finding, but here it's a little bit in the radius and also in the head of the, here in the base of the phalanx, there's some bone marrow edema. And bone marrow edema is always a bad sign because it shows the disease is very active, and you need to go the extra mile in order to do the proper treatment. And then we have this last sequence that is worthwhile looking at. You see there is again, the fat is bright both in the subcutaneous area as well as in the bone. And we can see that the destruction in the joint is not good to be seen because the inflammation is bright and also the bone. And if we compare it with the T1, so that's the T1 weighted scan that we already identified. And this is the T2 weighted scan that we already know now with slightly different signal intensity in the MCP joints. And if you now compare this with this last sequence, you see the contrast is a little bit different, but it shows up bright. And what's bright, not only on a scan, is not only fluid on a T2 weighted scan, but also gadolinium, meaning contrast agents, but on a T1 weighted scan. So we see here the example of a T1 weighted scan with gadolinium injection, but without fat saturation. So that is again something that some institutions still do. They perform a T1 before the gadolinium injection and they perform a T1 after it, and then they make a subtraction. But due to the long time between the first sequence and the last one, usually there are some movement artifacts and image quality is not as good as if you perform a T1 weighted scan with fat saturation. So this is just a short walkthrough this amazing case with rheumatoid arthritis. Remember, it's a 30-year-old woman who suffers from rheumatoid arthritis already for 5 years, and you see the disease is not well controlled. There's very active joint inflammation in many joints, the PIP joints, MCP joints, and the wrist. And this is something, this needs to be addressed by therapy through the rheumatologic experts, and radiologists are here to diagnose it correctly, to not mistake it for anything else, for instance, gout, and to create beautiful images and to diagnose them. So it's worthwhile going to RheumaXP.com to see the agenda, to book the course, and to learn from Sergio Viana Lopes during the next 12 months, because he will be available with WhatsApp and other means of communications in order to help you understand your cases. Thanks for watching, and see you next time.